So 61-year-old female, she is 1.5 years after a transvaginal suture-based repair of a vaginal prolapse. She had a cystocele and a rectocele repair. She complains of a recurrent vaginal bulge. She's symptomatic. She has pressure and heaviness. She also has a little bit of stress incontinence with heavy coughing and a feeling of incomplete emptying, and she's a smoker, so she's pushing some pressure. Here's her POP-Q numbers. So as you can see, she's got...
Sandeep, maybe we need to make sure we understand POP-Q. Everybody is comfortable with POP-Q numbers here? Yes? No? Okay.
So just for those you aren't, dominant anterior apical prolapse and a little bit of posterior wall prolapse. Probably a little wider, a genital hiatus as well. So and her total vaginal length is 8 centimeters, so she hasn't been shortened or anything, at least at this point in time. She's sexually active, so how do you want to counsel her? So now, again, she's had a hysterectomy in the past, before, and she's now failed a traditional repair, the repair type I showed you. She's failed that, and she presents to you. So audience, anyone want to go up? Feel free to just yell out what your thoughts are.
So Zilla, what do you do in your unit since you... Or you're not sure, that's why you came? Good. Can go to my... Yeah.
We traditionally I would offer her a secondary native repair. However, recently all my patients get transperineal scanning, and those patients who have levator avulsion, we are now deciding whether we should then offer them mesh placement with those who have bilateral avulsion. So we haven't yet made that move, but we're looking into that. I operate with a colleague, and he's of the opinion that if a patient presents with a recurrence, that he uses an elevate mesh for that.
Just a question, do you offer pessaries at your place?
Yes, so we've got a database of about 300 patients on pessaries. So I offer all my patients as in the consulting room and conservatively managing with a pessary, and if they opt for that, we have a pessary clinic where we see these patients back.
And if she was like 85, would you consider colpoclysis? You do that as well?
Yes.
Okay, great. So maybe we can have a show of hands. Who would do a transvaginal mesh repair here, and if so, what product would you use? You want to use
Raise
the microphone?
your hands.
Yes. Yeah, she just raised her hand. You want to use the microphone and tell us what you would use?
I would use I'm Lia from Brazil, I'm a urologist. I would use a mesh from Promedon that I am used. I trained a lot this kind of mesh. So I would propose this mesh for the patient.
Okay. And there was someone else in the back who's doing mesh as well? No, okay. So there was one mesh. Who would go for an abdominal options?
How old was the patient?
61 sexually active. Anybody for mesh laparoscopy? Any hands? Mesh robotics? Mesh open?
So sacral colpexy, we don't have many sacral colpexy takers, no?
Anybody would do anything else vaginally?
Everyone else vaginally, so I'm going to assume it's going to be some sort of vault suspension, right? She's got an apical issue, so she's going to need, post-hysterectomy, uterosacral, sacrospinous ligament fixation, one or the other, correct? And maybe a cystocele or a rectocele, depending. Okay.
Good.
So that...
Question about biological graft. Who is using biological graft in the room? And which one are you using, Elise? You want to grab the mic? You need to sit closer to the mic here.
I'll control myself. So I typically will use a human cadaveric dermis by Coloplast. Mm-hmm. And I find that the reactivity to the porcine tissues is too high. And sometimes the patients end up with a fluid collection or absence of the porcine tissue, and I don't see that with the human tissues, but there's no good data really on that.
And can you share with us how many you've done and what has been your long-term experience? I mean, I don't want to put you on the spot. I
haven't studied it, but I may have done 100 sacrospinous ligament with a cadaveric dermis in a situation like this. Mm-hmm. With more prolapse, I would use alternate options like a uterosacral ligament or a sacrocolpopexy.
Okay. And would you typically do somewhat of a plication as well, and then augment on top of that with cadaver tissue, or just use that alone?
Whether I'm anterior or posterior, I always do a site-specific or a plication in addition to whatever else I'm doing with a cadaveric graft.
Got it. Good. Okay, any other thoughts? Anyone else do anything different? Again, you can go, and it's patient choice. So in her case, it was a robotic sacrocolpexy. So she had failed prior repair. She had an apical defect. She had an anterior wall defect and somewhat posterior wall. She's sexually active. She's looking to be so. She's in her case, a couple other things that probably weighed in a little bit. Smoking history. I couldn't tell you her weight, but suffice to say she lives probably in Cleveland, Ohio, so she's probably a little overweight. So there's other factors that way that I think will be weighing down on a repair, and perhaps one of the reasons why she failed her original repair in the first place. Within a fairly short period of time after her original. And here's her picture.
Sandy, you mentioned that you had a little bit of incontinence. Maybe we'll have more discussion with another case on that, but...
I don't, but I know Kim does.
Okay, so in a case like that, how much did that play into your decision? Do you do a robotic birch at the same time? You put a TOT at the same time? Or you just live with it and see what happens?
Yeah, so I've become more and more selective, but I'll offer it to patients. But more often than not, on a patient like this, if I was doing a robotic case abdominally, I would probably do a transobturator sling or some form of a sling at the same time surgically. So most of those patients will opt for that sling. It seems like their comfort measure more is, you're already talking about mesh, because the better evidence certainly favors mesh use if you're going to do something abdominally. So in those cases, I would talk to her then about using mesh for her sling and kind of go from there from the discussion. If she was comfortable with that, that's how we'd usually proceed.
And if she did not want to, then you live with that. And you can always do it later on.
You can always do it later on and be selective. But and again, just because she has it clinically beforehand with heavy coughing does not necessarily guarantee she'll have it afterwards either, even with reduction testing and everything
And
else.
she has to stop smoking for 6 weeks before you operate on her, or
It'd
are
be
you
nice,
that demanding?
That's wishful thinking, Philippe.
Right.
Lose weight, stop smoking, and I'd have a no surgical practice.
All right. Any other questions? Yes, Ilya, go ahead.
Yeah, if there's no robot, again, I don't do laparoscopic, but otherwise I think laparoscopic sacrocolpexy is a fine option. Again, all the options presented here, any one of them are certainly good choices. In my hands, it would be vaginal, and I'd usually use a traditional sacrospinous ligament fixation with anterior repair as well.
I'll just add to that point that you can do a small fan steel and do the whole operation as well, like that. So, for a younger woman, she's 61, so she's not like 45-year-old Miss America, but as she said, she's a good BMI and she's a smoker, so she won't compete for Miss America anytime soon. But still, you can do a fan steel that is a great approach. The only problem with the fan steel is that the dissection posteriorly can be hard because you're coming from on top. So, but you can position the table frontwards, and with a clamp in the vagina, you can usually see the back wall pretty well. That's the only part that can be a bit tricky when you dissect. All right, any other question about this? Everybody's on board? Okay, let's move on to our next case then.
Okay,
Can we turn the lights down, please?
This one's a little different twist. We're going to talk about this because we've kind of alluded to it. So it's a 65-year-old female. She's status post or prolapse repair with mesh augmentation. So she had a trocar-based system 2 years ago. So she's already recurred also fairly quickly. She had a cystic rectocele and ball suspension. It was a total vaginal mesh system. She now complains with a vaginal bulge and pressure. She also has some vaginal discharge, dyspareunia, pain in the vagina and groin, yet no urinary symptoms. So she's no urinary complaints at all. She's seen several physicians who removed bits of mesh, given her creams, and no one can help her. So she's rather desperate. She comes to your office very discouraged because she's seen several specialists. And here's her POP-Q numbers, as is shown here. And she also has, and I'll show you the picture in just one moment, a mesh exposure in the mid-vagina. She has, we'll do point mapping for a lot of our patients who have mesh complications, just to really be specific as to where they have their problems. Hers mostly was on the left side for pain, her left obturator area, and we'll always do cystoscopies on these patients just to assure that there's no chance of mesh perforation, and that was negative. So here's her picture. Can we put the lights down even more?
Based on the operative note, do you know what type of mesh was used, or
So she had a ProLift.
ProLift,
Total
okay.
ProLift. Anterior and posterior. Now posterior, some of that, it seems like, based on the notes, had already been removed.
And so she
Anteriorly, I
went
think-
to the usual 6 weeks, 3 months of hormone cream and
Absolutely.
office debridement and the whole 9 yards.
Exactly.
Okay.
Someone, she's seen, I think, 3 or 4 specialists prior to coming to see us. But it may or may not project well in the back, but this is all mesh. So again, here's the area mostly of her tenderness, as I mentioned, kind of left groin area. But all of this is actually little bits of mesh that are really embedded within the vaginal wall. So remember, she's had surgery, repeat surgery, it's been thinned out. She probably had some level of vaginal atrophy to begin with, had a mesh system placed, and now again, she's got all this mesh really embedded within the vaginal wall after having, again, it's unclear what they exactly did, but they removed some mesh. That's all we really have for clarity from prior operative reports.
And Sandy, based on the picture you're showing, you can see an incision below the urethra, so she had a TOT or something done there?
Yeah, I think so, or
then
the
she's,
distal arm of the mesh. I can't tell. I
Okay.
think it was the distal arm of the mesh.
She has any voiding dysfunction? Because it looks like the bladder is down and this is way up, so...
Yeah, surprisingly not, but to your point, I mean, it was evaluated, she had urodynamics and cystoscopy, didn't show obstruction on urodynamics, and cystoscopic, again, there's no mesh perforation of any arms through the bladder. So we're probably leaving her outlet for later if need be, but right now the main concern and consideration is what's going on with her current mesh status, so.
Okay, so let's go on. Can you grab the microphone so we can hear your question? Can you say who you are,
Can you
please?
just clarify? So my name is Srini Yelapu from Australia. Can you please tell us, so just describe the anatomy here? With the,
Yeah, so
all the
obviously
instruments.
anterior wall, she's got a speculum here, so you can't really see the posterior wall as well. She's got a little bit of apical descensus too, and again, just to refresh your memory,
She has a 6 cm long vagina, so it's pretty
she's
short.
got some degree of shortening. Her C point is actually -2, so it's being pushed up a little bit with the speculum here. Does that help? Is that more clear? So now the question again is what do you want to do for all of this? She's got, as I mentioned earlier, recurrent prolapse. She's got symptoms, including bulge, but that's, I won't say secondary, but certainly not the main issue. The main issue certainly is more this, which is the vaginal discharge, dyspareunia, pain, etc. in the vagina.
I don't think it's dyspareunia, it's no pareunia.
Well,
with this,
probably no
correct?
pareunia, but it is part of it. So what do you guys want to do?
Who's brave enough to grab the microphone?
And again, probably no wrong answers here. I say maybe the wrong answer is trying to put another mesh system in, but if we take that off the table, what other options do you have?
Well,
Where are you from, sir?
I'm Eyal Goldschmidt from Israel.
Yes.
Not a very easy case, but I think that her main problem is the mesh, and I think that I would try to take it away vaginally. I've personally made just 2 cases, and it was not too difficult. It is difficult, but it's not impossible. Not all of her complaints, but most of her complaints, I think, discharge, dyspareunia, and so on and so forth, is due to the mesh. And since we are doing it vaginally, sacrospinous fixation maybe vaginally. Pretty good results and very easy. Yeah, that's it.
Yeah,
and
great.
And maybe a posterior repair, traditional posterior repair as well, since she has the BP was +1, right?
+1, yeah. And that's behind the
So
speculum here.
most probably, yes.
All right. So any other comments? Elise, what would you do? Or anybody else? Go ahead. Yes.
I think I probably prefer to go transabdominally because this lady had a number of attempts to have this mesh removed and it was unsuccessful. Because just from going from below, you can't see what mesh is remaining inside. So I need to really go transabdominally, in my view, to get the best result, to take the mesh out, obviously.
Great. Good thoughts.
I think you have to be prepared to use a flap vaginally when you remove that mesh, depending on how much you remove.
Yes.
And you also, abdominally, we should remember that we can access the uterosacral ligaments abdominally, even laparoscopically, so those can be really handy if you need to do a repair. And although the data isn't great and bleeding complications are known, you can always do a lateral paravaginal repair when you're sort of desperate, but this doesn't seem like quite the right situation for that.
I agree with your point on the
I think let's have
vaginal
Kim's
part.
opinion. And
Yeah, Kim and Philippe, what do you guys think?
So
This isn't
regrettably,
easy.
similar to Philippe, this has become a fairly large portion of my practice. And so this is a patient whom I would right off the bat let her know she was going to have a staged procedure. And I would get the mesh out, get rid of the pain, and then we can address the prolapse and pretty much reassure her that the prolapse is easy to fix. Out of all the things we do, that's the easiest thing that we highest cure rates. So I would do a transvaginal excision of mesh. Typically, you can pretty widely mobilize the vagina and then do a primary repair. I think the biggest trick is there's a fairly decent-sized case series of just under 100 women out of the University of Michigan who the problem is, even when you get all of the mesh out that's on the vaginal side or all the reasonably accessible mesh, those patients still have about a 50% pelvic pain rate of pelvic pain. So once the mesh was out and that healed, I would get her into some physical therapy for about 3 months where they were doing scar mobilization and myofascial release. Hopefully by that point, she wouldn't be in that 50% who had lingering ongoing pain. When we'd address the prolapse, I would probably counsel her about an abdominal prolapse repair using some type of sacrocolpopexy, whether it be through a mini lap, whether it be laparoscopic or robotic. I don't think the route of access is as important. And I think the reason I would favor an abdominal approach is because she has a 6-centimeter vagina. I'd be very hesitant to take any more vaginal width or length off. She's a young, reasonably young sexually active woman who already has pain with intercourse, so I wouldn't want to make her vagina smaller. And the other nice thing about when you go abdominally is the studies have shown that you can probably increase her total vaginal length by 1 centimeter or 2 by the strength and the durability of the repair you get when you go abdominally.
the only problem is you have to convince her that, after this mesh disaster, you're going to go back and put some mesh. That's where
I think that's the
many
biggest
of my
challenge,
patients
right?
struggle. So that takes some convincing. But I agree with the stage approach. I would do exactly the same. And I would add to that the challenge in those cases is the bladder and the ureter and not get into any one of them because this is a redo case already.
Multiple redo.
Right? Yes. So you could discuss stand placement at the time because the ureters are not far. And this vaginal wall looks like there's nothing underneath. So you're going to be right into the bladder wall.
That's the challenge here. You're exactly right. I think the vaginal wall part, which again, I don't know if you can appreciate it as well, but this is all the mesh because again, she's been so thinned out. We ended up having to resect all the way laterally.
Absolutely.
And going here, and there's no plane of vaginal wall to the mesh. It's different than other
You're lucky
mesh
because she has a
complications.
recurrent prolapse. She still has vaginal tissue, but you can have the same case with a very taut vaginal wall.
Yeah.
And you basically have a defect left because you have nothing to close over except for very super tight colporrhaphy. And that's maybe a question we can address in this group. It's more elaborate of a discussion, but marshes with skin flaps may be an issue.
So we use Surgisys in this case. So this is a porcine intestinal submucosa platform because we had to take out a good bit here. So that was exactly what we did the first step. So that was stage 1. Got her healed up. And
make sure the pain is gone. I think Kim
pain
is a very good point.
ultimately improved. I won't say it was gone. The challenge is to your point, Philippe, is the discussion about doing mesh for the apical repair abdominally, no matter the route, and she's still actively thinking about that. So she's still on plan at some point for having that managed, but I think it's going to take a little step of fortitude for her to go on to mesh placement abdominally even.
Is she
I actually
sexually
haven't-
active again now?
Not at the present time when I last saw her, no. No.
Although usually those conversations I think are a little bit easier when you don't focus on, like, it's not so much the mesh, of course you could have, but it's the way in which the mesh was placed.
Right.
Here in the
And-
Midwest, it should work out okay. I think it's harder for the people on the East or West Coast.
It is probably true. Any other thoughts about that? Questions? Because it's a little unique. This is the different twist here, I think. Again, her situation, she's had some shortening of her vaginal length. So that probably makes a bit of a challenge. We're certainly doing a sacrospinous, although it's a good option and good thought to do, concurrent vaginally management. And then, again, the fact that she's got all this mesh in a slightly different location than our typical mesh complications, which may be in the bladder, she's got pain or something else, but you've got a layer of tissue. In her case, we don't, so we had to get a little bit fancier, in this case, use a graft to manage her.
So I think the only point that we heard from some members here that they would have gone abdominally, I would say this would have been really hard to do abdominally because you're sitting below the trigone and the ureters coming from on top. So, sorry?
That's abdominal, you can watch. You can follow.
Yeah, but you can still get into them because this is very different.
Absolutely.
I mean, those type of meshes are hard to see. There's a fairly high recurrence rate as well because they're transparent,
Tissue.
mesh strands, and you'll have about, in my experience, about 10% people that still have some element of mesh exposed later on. Then you want to get to the arms on the side because you don't know if they're causing pain or not. That's hard to get to if you go from on top. So the meshes I've removed abdominally were most mesh-equical pexy complications when they are in the bladder or vagina high up. That's, I think, a decent approach. But a mesh placed solo down, I would say going from on top would be hard.
Go vaginally.
Yeah.
Any other thoughts on that case before we go on to the last case I have? So, okay. A little different, consistent with one of your other questions here. So, 44-year-old female presents with complaints of stress incontinence and vaginal pressure and some pain with deep relations. No other past medical history. She's otherwise fairly active and healthy. And here's her POP-Q number. So she's got an insight to uterus based on this. So her anterior and apical descensus are the majority to total vaginal length is 9 centimeters. She also has a wide hiatus. She had urodynamics, which showed a leak point pressure of 80. So stress incontinence, a little higher pressure voiding, but maybe because of the packing and so forth. So thoughts on how to manage her? Anyone here would do a pessary?
So anybody who has not got to the mic yet, come on, there's a few people that have not spoken up, and don't be shy. What would you do? You asked a question earlier. You want to tell us your choice? Laparoscopy? Remember, there's no right and wrong answer. This is not a board question, so go ahead.
I won't use a pessary because of the age and sexually active. I don't think that she will say okay for this kind of treatment. So usually,
Well, let's talk about that quickly because I think if you can convince patients, you'll maybe be surprised. Some will do much better than they expected. Mm-hmm. So I've learned to not necessarily say, no, I don't want a pessary. I want something to fix it. Some of them will, if you convince them to give it a trial, and they do, I would say, I don't know what, Kim, you have a pretty good experience with pessaries?
Yeah, so I think you can't go wrong here. So I would talk to the patient about all the different routes and find out which risk-benefit profile works best for her. I think pessary, I would always offer and talk to her about a pessary. I've learned to not, it's out there, here's a temporizing measure if you're not ready to have surgery. But the 45-year-old usually aren't long-term pessary takers. I agree with you. So I offer it. Sometimes, they're really busy at work. They can't get time off. They're a teacher. They have to wait till summer. I think it could be a good temporizing measure, but I think most 45-year-old women, probably they're going to live another 45 years.
And in this case, she's leaking because sometimes you put a pessary to see if they will leak during the pessary trial, which obviously you have established here as being the issue already. So, right. So we'll leave the pessary alone. Any question about pessaries? Because I think you also need a pessary in quote expert. If you really have not put pessaries and you don't have all the different size and shapes, you may not feel comfortable. But if you're in a place where you have that and a dedicated person that will do your pessaries, you'll be surprised how many people end up doing quite well with it. It's not different than putting, a cervical cover or anything else. So yes. Yeah, pessary with a knob that can help for incontinence. Yeah. All right, let's move on. We've talked about pessary. Let's talk about surgery. So, transvaginal, transabdominal. What would be your choice? You said laparoscopy.
Transabdominal, but with laparoscopic approach, and sacrohysteropexy will be my choice.
And what product do you use for the mesh?
Gynecare mesh.
Gynecare mesh. And how many sutures and what type of sutures do you use?
2, sometimes 3 for the cervical portion, 2 from the sacrouterine ligaments, and sometimes 1. But what we see always when we use the middle suture, mainly there is dyspareunia, so only 2 sutures now we are using from the sacrouterine ligaments. And also for the promontorium, we use usually 3, at least 3, I mean.
Okay, all right.
But we are using sutures non-absorbable for the sacral one and absorbable for the cervix.
And you're using 3 out of rather than 2 or 1 just because you've had some failures when you use 1 or 2?
Yeah, we have seen.
Wow, very interesting. All right, any other comments? Any other
thoughts? So she's what, 45, 44, and she's done having kids. Anyone here want to do a hysterectomy? She might want it, right? I mean, it's a discussion point, right? Once again. Based on her numbers, certainly you can justify it. So in that case, we'll assume someone's going to do a vaginal hysterectomy, some form of apical suspension, probably a sling, but again, open discussion. I'm going to just twist things around a little bit. Let's say your POP-Q is a little bit different, and you mentioned, and that's a very good option. Let's say she wanted to keep her uterus, so to that point, she opted out of a hysterectomy, whatever route. But now let's change your POP-Q a little bit to this. So I'll just, for the group, highlight the difference here. Her cervix is at +1. Her cervical length now is about 4 centimeters, so a good bit longer. Would that change your management for her? So now she's got a longer cervix. And let's say she did opt for uterine preservation. How would you change anything around?
Let's make it like a 7-centimeter cervix.
So let's make it even more fun, Kim.
This is Texas here. Everything's big.
If you think it's only 4 centimeters, you're still, like, even if you consider it prolapse when you fix it, it's still stage 0.
Okay, so we're going to go up to 7 centimeters. We're going to make it even longer. Thoughts?
My name is Mette Bing. I'm from Denmark. I think the very good option here is a cervical removal and then an anterior repair. We call it a Manchester.
Mm-hmm. Okay.
Any other thoughts on that? Does anyone else want to go abdominally, laparoscopically, and do a little?
I'll leave the cervix as +1, and I would traditionally do an anterior colpotomy with a sacrospinous ligament fixation for the apical onto the cervix.
Okay, but she still has a lot of cervical length, right?
Yeah, then you could, your sutures go onto the cervix, and you traditionally open up, visualize your cystocele. Your incision usually goes down on the paracervical tissue, and then you would do your Ruchter's procedure, whether you could do it unilaterally or bilaterally. So you would then, in that way, you would address the anterior compartment and the central compartment with your sacrospinous ligament fixation. cervix, I'm saying cervix +1 or 0, not +7. It's too long to do that.
Right. So
Yeah.
so for +7, that's going to be too long, right? +1, you might do that.
Hi, I'm Safa Tossa from Gibraltar. Years ago, I used to do quite a lot of sacrospinal fixation, but again, you get a good result, but it depends how long the cervix itself is. If the cervix is 4 centimeters, still the patient might be able to feel it. And I found that if you amputate the cervix as high up as you can, you actually get very good result for these patients, and they are satisfied with the procedure. And that is a lot easier procedure than doing any of abdominal approaches, and a lot quicker as well.
Good, good. Any other thoughts? Kim, Philippe, any other thoughts on that? +7. We'll give you +7 on the.
We're +7. Well, her C is still low, so she's got apical prolapse regardless of C elongation.
Right.
Well, regardless of cervical elongation. But I think you need to do something about the cervix. So my first choice, I would talk to her about lots of different options. My first choice is she said, hey, doc, what would you do? I'd probably lead towards a vaginal hysterectomy with uterosacral ligament suspension. If she was really, really, really attached to her uterus, I would probably favor some type of a mesh, abdominal mesh hysteropexy, like a sacrocolpopexy, but addressing the cervix, whether you sort of did a modified Manchester along with your sacrocolpopexy. There's a couple people that I've just aggressively leaped at the same time with this, is the sacrocolpopexy to trim away some of the cervix. But in all things being equal, I think the better part of valor is to get her cervix out if you can get her to agree to it.
So I think we agree. If we keep the cervix, you have options vaginally or you have options with mesh. And if you go abdominally, you can do a supracervical hysterectomy as well. If she has had bleeding or fibroids or anything else, and just fix your mesh to the cervix so you decrease the risk of erosion. That's the only variation.
Yeah, in her case, she went to the standard route, just wanted to have her uterus taken out. And it's funny, in the States, there's probably, and you guys will both appreciate, probably in the Midwest, they don't seem to, I won't say it's education, but they just don't seem to fixate as much on the uterus, whereas the East and West Coast, Chris, correct me if I'm wrong, I mean, they would be much more, the first discussion would be about uterine preservation, and then now that we're going to keep my uterus, how are you going to fix me? True?
There is that component. It's all over the
Is it? Okay. But yeah,
The
in the
East and the
States, I
West
think.
Coast are the worst.
Yeah, that's my sense as well. In the Midwest, they tend to never complain. So, great, thank you.
Go ahead.
My name is Per Larsson from Sweden. In case 3, if she were 28 years old and had Ehlers-Danlos syndrome, what would you do then?
So 20th-year-old with Ehlers-Danlos syndrome.
Completely the family.
So,
So
it's a
everybody
20
knows Ehlers-Danlos syndrome. So it's a disease it's a collagen deficiency disease, basically, where people have tremendous prolapse. They're very young in age when that happens. So this is a totally different, issue altogether.
So 28-year-old, higher risk for recurrence because of underlying connective tissue disease, 7-centimeter cervix that I would want to get rid of. So she's someone who I'd probably lean towards doing some type of a sacrocolpopexy, mini lap, laparoscopic, robotic, whatever your colpopexy of choice is. I would do a total hysterectomy rather than a supracervical hysterectomy, knowing that I have a slightly higher risk of mesh erosion, but I'd want to give her the extra durability of the mesh. And then keep my fingers crossed and pray. Because her cervix is 7 centimeters long. Mm-hmm. And although it's not been necessarily definitively associated with with connective tissue disease, if I had a 28-year-old Caucasian, which is, you see less cervical elongation in, and an 8-centimeter cervix, I'd be thinking, oh gosh, could this be related to underlying connective tissue disorder? And I just want to get rid of it.
Yeah, I think the point of this case, don't fix it vaginally with your own tissues, it won't work. So we're going through our own cases, but if you have cases from your own institution that you want to present to the group, feel free to to share with us as well. Kim?
Yeah, mine are more sort of just generic points for discussion. So this patient is a 75-year-old multipara who, as you can see, has stage 4 vault prolapse. She has bothersome symptoms of prolapse, as you can imagine. She had a vaginal hysterectomy 30 years ago for bleeding. She has no incontinence, neither urgency nor stress incontinence currently. She's not sexually active and doesn't plan to be. So what would people's first, second, third line alternatives be for this patient and why? Okay.
And can we add to that she tried the pessary, and as soon as she stood up, the pessary rolled out?
Well, I mean...
You can try it.
Right,
Yeah.
you could try it. She may not want it, and I think that's okay too. So Dr. Payne said he would do a colpoclysis. Do people do colpoclyses? Yeah. So that would actually be my first choice on this patient as well. And I think there's pretty good data to support that these are some of the happiest patients with the most satisfied after the case. So would you do anything for her incontinence or to potentially address it? Chris, you're on the spot now.
Well, you gave me the no incontinence. You made it easy.
Right. So what could she have incontinence? How are you going to counsel her about her risk of incontinence after you fix it?
All I can say is it's not fun to go back.
Yeah. So we'll talk about this a little bit more, but obviously this patient still has at least a 40% chance of occult or unmasking stress incontinence at the time when you do the colpoclysis. I think there's not great data out there for colpoclysis. There are a few small case series that show if you do put a midurethral sling in these women for either symptomatic or occult stress incontinence, takedown rates are low in comparison with fascial sling, where people were putting them in at the time of colpoclysis for fascial sling probably 10 years ago, which takedown rates were probably upwards of 10 or 11 to 15% in the first few weeks after surgery. I probably would stage her regardless. So I would probably do the colpoclysis, not address the incontinence. I may reduce stress test her, just so we all kind of know going in what our a little bit better chance, what our odds are, but I probably wouldn't aggressively treat her for occult incontinence.
Kim, a patient like that, I mean, you said no incontinence, but you didn't talk at all about retention, avoiding dysfunction, bladder infections. Would you do urodynamic to see what type of detrusor contractility she has? Would that influence your decision for or against the sling or not?
It would not. There's pretty good data that about 90% of time, 90% or better of the time that you take patients with colpoclysis or advanced prolapse, even that have elevated post-void residual volumes, when you fix the obstruction, i.e. the prolapse, over 90% of those patients, the retention resolves. We did probably maybe 6 years ago, I think it's published in the International Journal, a case series of just under maybe 28 women who, many of whom had retention, had positive stress tests preoperatively, just a cough stress test, and retention, had colpoclyses and midurethral slings. And I think there was one patient in that series that had prolonged voiding dysfunction after it. So I think that there's increasing data that even in the presence of retention, once you reduce it, you're probably going to fix the retention and the elevated post-voids. I think that...
No, I would agree with that. The question was more, if you do a sling, does your dynamics of avoiding pressure helps you make a decision or not?
Yeah.
Would people do urodynamics in the room on a patient like that? Philippe and I can
have a long debate about pressure flow studies and urodynamics.
Yeah, no, but just anybody doing urodynamics?
I would not.
Yes? Who would do urodynamics? Just raise your hand so we have an idea. Okay. And how do you use the urodynamics? I mean, how does that play a part into your final treatment decision? Do you take it for counseling purpose, or does that change your management? Patrick? Going.
I'm Patrick Dufeuille from France. If you have a low pressure on the urethra, pressure very low.
So you do uterine pressure profile, and you do liquid pressure. Okay.
It's very low. It can you have to tell the patient that you can have failure with a sling, and also if you have a retention because of the hypertony of the bladder, you can prevent. You can tell her that you may have acute retention afterwards.
And when you do your UPP, you reduce the prolapse, or you just do it just like that? Because she's supine, correct? So do you?
I reduce the prolapse. Yeah.
You reduce the prolapse during your UPP. Okay.
Yeah.
Thank you, Chris.
I almost completely agree with Kim. I would just do
Only almost?
a PVR and a reduced stress test. But if she had really bad incontinence and a low PVR, you would still stage it? You wouldn't do a sling?
No, I would do a sling on the patient. No,
yeah, then
totally.
I agree with Kim. I don't think urodynamics...
He completely agrees with you now. Okay.
Yeah, I don't think the urodynamics are going to be very helpful unless you had a combination of apparent bad stress incontinence and a high PVR.
Another question, since you're both of the mic.
Even if she had no symptoms of incontinence, I would talk her through the fact that over 90% of the time, if not more, the retention's going to go away. Yeah. And she still has at least a 40% chance of stress incontinence. And if she wanted a prophylactic sling, I mean, 75 can be really different. I mean, like, she's a 75 active farmer's wife, and she wanted a prophylactic sling, I would give it to her.
Now, Chris, stay there for a second. Chris, one more question. Large prolapse like that, we used to be taught we have to study the upper tracts. Do you do upper tract studies on that, like a renal ultrasound?
I do a creatinine.
You do creatinine?
Yeah, I mean, the upper tracts will get better. So if they don't have elevated creatinine, they're already 75, I'm probably not going to bother to get an ultrasound.
Kim, any upper tracts evaluation at all in your practice?
There's good data that there's likely that she may have some bilateral hydro, although the majority do not, because the nice thing about prolapse and the type of obstruction from prolapse is when you go to bed at night and go supine, it relieves the obstruction, unlike a prostate. But even if they do have bilateral hydro, it doesn't change your operation, and the hydro often resolves once you fix the prolapse.
I would only do it as a baseline if you were really concerned. I was going to add one more twist to the urodynamics, and that would be as if she was diabetic. If I really needed to get a little bit more information on her voiding pressures, I think
So if
diabetic.
90% of the time, with no urodynamics, the retention resolves.
Absolutely.
And there's never been a single urodynamic parameter avoiding that predicts anything.
True.
Except when we work really hard, we can say P-DET at maximum contraction predicts stress incontinence, which is completely counterintuitive. Why? I mean, I'm just really curious. I mean, I used to do that. I mean, but it just, what additional information are you going to get when half of normal women can't void at urodynamics?
Well, there's a couple of scenarios you can think of. One is Valsalva voiding. If they push a lot to void, they can tear your repair down by pushing and straining afterward. If you're not doing a colpoplasty, if you're doing a standard repair, and you have someone that pushes a lot to void, that may change your approach. You may want to leave her on longer catheter drainage for a while. I think, 10%, I'm not sure that I'd buy that completely. I think we see more than that, but this is the data you have. There's not a lot of data in literature, but I think to me it's more like 25 to 30% people have voiding dysfunction still afterwards. So I still like your dynamics for counseling purpose, because when I see a good diffuser function, then I don't worry. But if they have this interrupted stream, they push a lot, they have no diffuser contraction, I'm worried that the retention may not go away, and I like to share that with them first, especially if I'm going to do a sling, which in that age group has a risk of retention. So if I have a prime afterwards and I don't know how they are at baseline, then I don't know if it's the way they were or if it's basically because of the operation I did, which has some implication, because you can take down the sling if they can't void. You see what I'm saying? So having the baseline, I think, can be useful at time.
Again, I'd only add that I could probably look her in the eye and give her very good certainty, to your point, that she'd empty well no matter what I do here. But in the odd scenario that I'm dealing with potential incontinence and she's got any level of neurologic impairment, diabetes, anything else is a significant factor.
She's 75, she's got neurologic impairment for sure.
Okay, just in the interest of time, let's move on because we have a few more minutes, and that's a great case. So go ahead.
This is a great discussion, though.
Kim, we torture you here. Go ahead.
Yeah, that's okay. So here you can see the prolapse. Here's another patient that has a uterus. I actually do it the same way with or without a uterus. Here you can just sort of picture the outline of the Foley bulb, so the bladder would be out here. And you essentially just quickly denude the anterior vaginal epithelium, then take a similar swipe out of the posterior vaginal epithelium, and then you leave these epithelial tunnels, which even if I'm doing a complete colpectomy, like not a Le Fort without a uterus, I often leave these little islands of vaginal epithelium, particularly during teaching other residents and fellows. It helps them stay oriented. And then you literally just put a series of imbricating sutures in where you sew the anterior endopelvic fascia stuff, whatever we're calling it this year, to the posterior endopelvic fascia. And you can just see you start to reduce the entire caliber of the uterus or the vagina inward. Then you do a high perineorrhaphy. You can do that in 45 minutes, and those patients go home the next day. The oldest person I've ever done it on is 99. I did it late on a Friday night. We got bumped, and so she didn't get out of the OR till midnight. I came in on Saturday morning with my hair in a ponytail, no makeup on, thinking she would stay till Sunday because they normally go home the next day. She was sitting up on her bed, fully dressed, looking way better than I did, and ready to go home. So it's a really nice option in a carefully selected group of patients.
So we'll do one more case and then we'll leave it to that.
Okay.
Yeah.
52-year-old multipra, stage 3 prolapse. She opted after counseling to undergo laparoscopic supracervical hysterectomy and abdominal sacrocolpopexy. She has no symptoms of incontinence. So kind of to Philippe's question, would you do urodynamics on this patient?
I think we talked about the urodynamics, so you want to move on to...
Okay.
Yeah.
Flash. You want to talk about continence procedure in this patient, or do you want to skip this one too?
I think you should move on to
So this is actually a case that's published in the journal called Obstetrics and Gynecology that if any of you are doing minimally invasive sacrocolpopexies, it's probably worth a look. It was a case out of University of California, San Diego. A 63-year-old, otherwise healthy woman came back 4 months after a robotic sacrocolpopexy. She was having some back pain that kind of continued to get worse. She did have one sort of episode of a vaginal yeast infection somewhere during her postoperative course. She had permanent polypropylene mesh, permanent sutures on the vagina to the mesh, and then separate permanent sutures to the sacrum. She came back. They finally got an MRI because of this persistent low back pain that was out of proportion. This is probably the thing that really got people starting to publish a lot in the literature about where the disc is. This was her initial MRI. And you can see, here she's supine, here's the promontory, and you can see this big lytic lesion, which they went back, they removed the entire sacrocolpopexy mesh. She gave her when they cultured it, it actually grew out yeast. She didn't get better. So finally she ended up in, you would have to read the article to find out all the different names of the procedures that ortho did. But essentially they had to remove her entire sacrum and put these steel rods in. And this is a mesh, not for the vagina. They didn't fix her prolapse. But this is essentially her sacrum now, her sacral vertebrae. And so I think that the teaching point here is I do a lot of sacrocolpopexies. I put in a lot of mesh. I also do a lot of native tissue repairs. But one case like this in a million, and I've never seen anything this bad for a recurrent prolapse from a native tissue repair. So the point with there is just, it's also lowered my threshold if someone comes back in after sacrocolpopexy with back pain. And I'm much more careful to make sure I'm on the slope of the sacrum. So.
Kim, do you think, I mean, we've only talked about it more after this report and all of us who see and manage these types of things, but when we were using more multi-filament sutures, let's say 10 years ago, and other factors, do we just brush it under the rug and we never talked about it? What do you think? What's come up lately? They're just coming out of the woodwork.
I think it's where we're putting it. I mean,
You think because of the minimally invasive?
I'm still using Gore-Tex. I mean, like Gore-Tex, and I've never seen anything like this.
But when people were using ethibonds
right,
and other
but
things
a few
more.
years ago, we were putting it down here.
Because you're doing open.
Yeah, and the group at Loyola in Chicago recently did some cadaveric work and looked at how long, and I have a nice little video of a cadaveric dissection that I did, how thick the ligament is. And so the ligament at the promontory, where 75% of women have disc right underneath, is about 2 millimeters. And then they did a bunch of, just had random expert surgeons suture, both laparoscopically and robotically, to see how deep the suture placement is. And for those of us who started out at S3 and have moved up to the promontory, I mean, the first thing I ever said was, oh my gosh, the ligament is so much better here, probably because it's not a ligament, it's a disc. And I think we get lucky a lot of the time. But they found out that when you suture laparoscopically, on average, you were 2.5 millimeters, so you're beyond the ligament. And robotically, they were like, the mean depth was about 3.7. And I do think that your risk is higher robotically, having done both, because you can just, I mean, you can make, in a cadaver, I've actually played with this, and I can use a robot, and I can drive the robotic needle without tremendous effort, you know, just kind of pull it back, push, through flat on bone. I mean, mind you, it's a cadaver's bone.
Right.
But
All right, so I think the time is up. Thank you all of you, first to come, second to participate. That was very enjoyable. Don't forget to fill out your applications. We have done this course for many years. We always listen to your comments, and we appreciate it very much. Enjoy the rest of the meeting, and if you have any question, we'll be here for a few more minutes. Thank you again.